there is more data and more push for the use of intravascular imaging to guide stenting, but few explain exactly how you do the measurements before and after stenting and what are your endpoints. I will try to explain that in detail, and I will explain some pitfalls, including pitfalls of the recently published Illumin IV OCT trial. The criteria I will use are obtained from the major trials. I tried to combine them and synthesize them for you. I suggest also that you review my 3 prior talks regarding IVUS and OCT imaging. This talk will complement the prior talks. First, 2 major randomized trials have proven the value of intravascular imaging in reducing target vessel failure, mainly target vessel revascularization, target vessel MI, and stent thrombosis. You have the ultimate trial, which used IVUS in all PCI complexities, and the more recently published Renovate Complex PCI trial, which allowed both IVUS or OCT, and it selectively applied imaging to complex PCI. IVUS was used in about 75%, OCT in about 25% of patients in that trial. And these are some of the results. There was a dramatic reduction of target vessel failure at 2 years in Renovate trial, 7.7 versus 12.3%. There was even a reduction in death from cardiac cause by about 2% at 2 years. Again, this trial took complex lesions such as bifurcation, CTO, left main, lung disease, severely calcified disease, ISR. This is from the ultimate trial. Interestingly, the benefit from IVUS compared to angiography guidance accrues between 1 and 3 years. So IVUS provides intermediate but also long-term benefit on stent patency. Now let's talk about stent sizing. First, with any lesion, you have to define where to land your stent, and this is what we call a reference, distal reference and proximal reference. The lesion stenosis itself is measured as the lumen of that stenosis compared to the lumen of the reference. We do not compare the lumen of the stenosis to the full vessel size, or what we call external elastic membrane area, media area. We compare the lumen of the stenosis to the lumen of the reference. However, the reference zone is defined by comparing the lumen and the plaque to the whole vessel area at that site. And the reference is defined as a plaque burden less than 50%, meaning the plaque area divided by that whole vessel area less than 50%. Now, be careful. We do not stent an area that has a plaque burden over 50%. Definitely not. Most those with plaque burden over 50% are not hemodynamically significant. We define stenosis severity lumen to lumen, and it is severe if the diameter stenosis is over 70 to 80%, which corresponds to a plaque burden area at the lesion site way more than 70%. It's just that when you have decided to stent stenosis, it is preferred that you land it in a healthy area with a plaque burden less than 50%. This will help improve the stent flow and the long-term stent patency, especially edge restenosis. Remember, no cutoff by imaging reliably correlates with functional significance and with when we should stent. It is best to use IFR, FFR for that. But if you use imaging, a lesion plaque burden area at the lesion site more than 70%, along with MLA less than 2.75 to 3 millimeters square in vessels more than 2.5 to 3 millimeters, is the cutoff. But even that lacks specificity and even sensitivity compared with FFR. And this is an illustration. This is an area with a plaque burden over 50%. This is the lumen. and the media is that black band. The plaque is that whitish semi-crescent zone inside it, and that is more than 50% of the whole media area. Conversely, this here is a plaque burden less than 50%. So this is a good reference zone, whereas this one is not an ideal reference zone. However, that doesn't mean that this needs to be stented necessarily. Only if you have a tight stenosis next to this and you need to stent, you probably ideally should extend your stent to a healthier area than this one. One issue is that in patients with heavy diffuse plaque burden, you may not be able to find an area with plaque burden less than 50% around the stent, and you may have to land your stent in a zone with more than 50% plaque burden rather than end up putting a very long stenting. You're choosing basically to stent the critical stenosis and leave the surrounding moderate disease alone, as there is no evidence that stenting moderate disease is better than the natural history of the moderate atherosclerosis itself. Now, another complicating feature here is that sometimes you don't see the external elastic membrane. So it's hard to tell what's the plaque burden and what my reference would be. This is particularly the case with OCT because OCT has less depth penetration than IVUS. And also with OCT, lipid plaque create a lot of shadowing, so much so that you may not be able to see that external elastic membrane and measure the vessel area and the plaque burden. So by OCT, you may have to choose as reference the segment with the best looking lumen around the stenosis area, the best looking lumen, or with a luminal stenosis less than 30% compared to the best lumen. This is what was used in October trial. So the lumen of that reference zone is not more than 30% obstructive in comparison to the best lumen. Now, once we've defined the reference, how do we size our stent? There are two ways of sizing our stent. Never size your stent based on the external elastic membrane at the lesion site, because at the lesion site, you get positive remodeling and vessel expansion. So the vessel and external elastic membrane at the lesion site is significantly larger than the original vessel size. And if you size your stent to that external elastic membrane at the lesion site, you will way oversize your stent and cause edge dissections and perforations. So there are two ways of sizing your stent by IVUS and OCT. You can size it to the distal reference lumen or distal reference external elastic membrane. The traditional method of stent sizing is based on that distal reference lumen. You size it 1-to-1 or 100% of that distal reference lumen diameter. This is what was used in the original music trial and in the landmark, ultimate, and IVUS XPL trials, including for post-stent optimization. Now, you can use the distal reference external elastic membrane. You downsize it by up to 0.25 millimeters. This is especially valuable if that reference zone has minimal plaque burden, in which case that external elastic membrane is close to the lumen size. The more you have a plaque burden, the more there is discrepancy between the EEM and the lumen, the more you should use the lumen for stent sizing rather than the external elastic membrane to limit the possibility of edge dissection. Also, when you have a lot of plaque, it may be hard to delineate the external elastic membrane because you may get shadowing from calcium by IVUS and you may get shadowing from lipid by OCT. Also, it will be particularly difficult for OCT to tell the external elastic membrane when you have heavy plaque burden because OCT has poor depth visualization. So for initial stent sizing, you may use reference lumen 100% of that distal reference diameter, or reference external elastic membrane downsized by 0 to 0.25 millimeters. Now, after we've stented, how do you assess our stent expansion? To assess stent expansion, only the reference lumen is used, not the reference external elastic membrane. So you compare your minimal stent area to the reference lumen area, not the external elastic membrane area. And we call the stent is well expanded if the minimal stent area is more than 90% of the distal reference lumen area, or more than 80% of the average proximal and distal reference lumen area. So we use lumens of the references, not the external elastic membrane on post-stent assessment. Absolute values for stent expansion were also allowed as an alternative in both major trials. They allowed non-left main MSA more than 5.5 millimeters square and left main MSA more than 7 distally and 8 proximally. So they allowed either or targets. But I prefer the relative target as it makes more physiologic sense to me. Note there are two settings where stent expansion assessment has special considerations. Long stenting more than 28 to 30 millimeter, or stenting across a large bifurcation, large side branch with vessel step down. In those two cases, you have significant change in vessel size throughout your lesion. And in those cases, this is how you assess stent expansion. Your proximal stent, minimal stent area should be more than 90% of the proximal reference area. And your distal stent MSA should be more than 90% of the distal reference. You initially size your stent to the distal reference lumen or EEM, but then you pot proximally based on that proximal reference lumen or EEM, and you assess your stent expansion based on the distal reference lumen for the distal stent area and the proximal reference lumen for the proximal stent area. And those are slides from the trials Complex Renovate and Illumin IV that corroborate what I just described. And there are three targets on post-stent imaging. I explained the stent expansion target, but also there are two more targets: no edge dissection and no severe edge disease or edge plaque shift. And I will explain those. Regarding edge dissection, in order to be considered significant and to warrant further therapy, both major trials mandated that the dissection extends deep to the media and to be additionally either longer than 3 millimeters or wider than 60 degrees. A shallow dissection at the intima level did not warrant further stenting regardless of its length. So this is a significant dissection. It has to go deep and touch the media. If it doesn't go deep, if it's only split intima, doesn't matter how long or wide. It did not mandate further stenting in the major trial, particularly that OCT catches a lot of minor dissections. Now, regarding edge disease, edge plaque shift, Ultimate trial recommended that stent edges have less than 50% plaque burden, as is an ideal reference. For more than 50% residual plaque burden at the edges, Ultimate recommended repeat ballooning using an undersized balloon, not extra stenting. In the Renovate trial, not even repeat ballooning was specifically recommended. Now, I want to provide some pitfalls here. This is the edge of that stent, okay? Do not balloon or stent that edge solely based on a luminal area. For example, a luminal area less than 4 millimeters square. Also, even when you're using the relative criteria of plaque burden more than 50%, do not necessarily balloon or stent based on that. Ultimate suggested doing that, but that's not absolutely necessary. and certainly do not simply stent based on that. Keep in mind that most sites with more than 50% plaque burden or less than 4 millimeters square by area are not hemodynamically significant. It's ideal to have less than 50% plaque burden, but it's not absolutely necessary, especially in patients with heavy diffuse disease. And why you should avoid stenting those edges? Because stent progression, whether in-stent neointimal hyperplasia or neoatherosclerosis, is more aggressive than native moderate disease progression. You get 7 to 10% TLR at 1 year and 1 to 2% target vessel MI with stenting. Then beyond 1 year, an attrition rate of 1 to 2% per year of TLR events. Moderate disease progresses slower than that. In fact, neoatherosclerosis is more aggressive than native atherosclerosis because of the dysfunctional endothelium inside the stent. So I'm not a fan of stenting moderate disease, including moderate disease at the stent edge. So be careful with adding another stent because you don't like the stent edge. Actually, one of the pitfalls of Ilumine IV OCT trial is the recommendation to add a stent at the edge if its lumen is less than 4.5 millimeters square, which is a very liberal use of stenting at the edges. So I mentioned 3 targets on post-stent imaging: expansion, edge dissection, edge disease, plaque shift. There is a 4th potential target, but least important: stent malapposition. Stent malapposition has not been consistently shown to be associated with long-term events after stenting. In Renovate trial, one of the targets after stenting was no major malapposition, which was defined as more than 0.4 millimeter gap between the stent and the wall. And they recommended post-dilatation for that. However, it was not used in Ultimate and several other trials. And just a note here, stent expansion means the stent is not crushed. It has an excellent lumen in comparison to the reference lumen. Stent malapposition means there is a gap between the stent and the wall. Most imaging novices focus on malapposition because it's the easiest to see, but your focus should be on expansion, on the size of that. Now, once we've decided that the stent underexpanded, how do you post-dilate your stent? You post-dilate it using a non-compliant balloon at more than 18 atmosphere, and the size of the non-compliant balloon should be either sized to the external elastic membrane and rounded down from that external elastic membrane reference, whether distal, proximal, or the average of the proximal and distal external elastic membrane reference, you round it down, or you round it up from the lumen references, whether the distal or the proximal reference lumens, and you round it up to 0.5 millimeters. And in cases where you have a natural stent taper, like in lung disease or across a large side branch, you post-dilate distally based on the distal external elastic membrane or lumen, and you balloon proximally with a non-compliant balloon based on the proximal external elastic membrane or lumen. These are examples from Ilumine IV OCT trial. So this is the media, the black band on OCT, and this is the reference zone. They measured that external elastic membrane diameter in 2 orthogonal lines, and they chose the stent within 0.25 millimeter down from this measurement. This is another example. Here you have lipid plaque in this area and in that area, and lipid creates shadowing. So you don't see external elastic membrane in those sites here, but you do see the external elastic membrane here where you don't have lipid plaque. So they were able to get one external elastic membrane measurement across a total 180-degree arc So they use a stent that was 3.5 millimeter, slightly downsized from that external elastic membrane measurement. Here we have a distal reference where you cannot see the external elastic membrane over 180-degree arc because you have heavy lipid here. All this is lipid. You only see the external elastic membrane over a small zone here. So they use the lumen diameter for stent sizing. This is an example of an LED stenosis here that was stented successfully by angiogram. Now on the post-stent IVUS, you see at the edges, I'm just showing you the edges, there is a lot of disease at the edges. Look, there is a heavy plaque burden here. This is the lumen, and all this here and all the way till here, this is a plaque. So there is a plaque burden that is a little over 50%. So you should use your judgment here. Should I stent that? My preference is to not stent this because, again, it's my belief that stenting moderate disease is no better than the natural history of moderate disease. I want to describe the recently published Ilumine IV trial and why it failed. This is the largest OCT versus angiography trial to date. It selected complex disease, and it did not show an improvement in target vessel failure, unlike the two prior major trials. Why is that? You have to go to the design of the trial and see how you process the data you obtain by imaging. Some may think that the problem is with OCT, that OCT guidance is not as good as IVUS guidance. I don't believe that's the case. I believe the issue is in the way you process your finding and what you do with them. And the issue, in my opinion, in that trial is here. They recommended stenting the edges if the edge MLA was less than 4.5 millimeters square, which is very liberal and which inherently would lead to a lot of extra stenting at those edges. They also recommended stenting any dissection that has more than 60-degree width or more than 3 millimeter in length. They did not mandate that it is deep and reaches the media. And that's caveat again, I think you will end up with extra edge stenting. And this is from the trial. They did not report the number of stent, but there was a longer stenting by OCT versus angio guidance. And importantly, look at the duration of the procedure per patient. It was 50 minutes in the angio guidance and 68 minutes in the OCT guidance, about 35% longer. Also, the fluoro dose, 1.5 versus 2 grays, and the contrast volume was significantly more by OCT. And by the way, those pitfalls, longer duration, more contrast, more radiation, you see them in other trials. This is in the Renovate trial. You had more contrast volume in the imaging arm and more procedural time. Again, that same number, around a third longer procedural time. And this is from the Ultimate trial. Again, procedural time, 45 versus 60 minutes, 35% longer. Contrast volume larger, and there was a trend toward more contrast nephropathy in the IVUS guidance, but that did not affect long-term outcomes. Now, longer procedural time and radiation dose and contrast are due to more post-dilatation, more time spent to analyze the images, and some of it is due to more initial lesion prep, which is a good thing. There was more lithotripsy or cutting balloon or atherectomy prep in this trial with OCT versus angio guidance. And it is okay to invest extra time to analyze your images. The worst thing you can do is do your IVUS and your OCT and just eyeball the images. You'll be going from eyeballing an angiogram to eyeballing ultrasound images. That's not the point of doing imaging. You need to obtain objective measurements. And I actually, these days, I mandate for my fellow that they put in the report the exact pre and post IVUS measurements to prove that we analyze the images. So it's okay to spend time to analyze the images. It's okay to spend time to do post-dilatation if needed. However, don't exaggerate it. Don't stent the edges excessively. Don't necessarily keep repeating the IVUS after every post-dilatation. So be reasonable, because yes, those procedures do come at the cost of a longer procedural duration, longer radiation, and more contrast. Now, more contrast, some may think is due to OCT. Yes, OCT necessitates contrast injection for imaging. But even in IVUS trials, you did have more contrast use. It's because you're doing more procedures, more lesion preparation, more post-dilatations. So with all this, you end up requiring more imaging. It is true that IVUS may be used for ultra-low contrast PCI. In those cases, IVUS may help you use a lot less contrast than angio guidance PCI. But on a large scale, where you're not particularly focusing on doing ultra-low contrast, IVUS eventually is associated with a more contrast, simply because you're doing more lesion prep and more lesion post-dilatation. And note, this is another OCT trial published at the same European Congress meeting 2023, which was strongly positive. This was OCT versus angio guidance in complex true bifurcation stenosis, and OCT guidance was associated with a significant reduction in target vessel failure of 14 versus 10% at 2 years. Importantly, they were more conservative in treating edge stenosis. They used luminal stenosis more than 30% to necessitate extra stenting, rather than using an absolute area of 4.5 millimeters square, which is very easy to meet. Residual stenosis over 30% will correspond frequently to a plaque burden more than 50%. They also use a more restrictive definition of edge dissection. I think that's one of the reasons why OCT guidance was more successful in this trial. It could also be that selecting more complex patient, the bifurcation disease, is more likely to benefit from OCT guidance. Yet this trial had some of the same OCT caveats and even more. Longer procedural time, 80 versus 113 minutes, 33 minutes more, 41% longer. Also much more contrast use, 300 versus 200 milliliter, a massive 50% increase in contrast use. Also longer stenting, hopefully appropriately so, considering the improved outcomes. I will finish with this trial also presented at ESC 2023 and published in Circulation, the Octivus trial. This is a large trial comparing OCT guidance versus IVUS guidance, and it showed the same long-term low risk of target vessel failure, again showing that it is fine to use either modality as long as you know how you react to the data properly.